Yeah, so we can have a talk about approach to cataract surgery in glaucoma patient, and yeah, it'll be great to get your input as we go along. So question one, if a patient presents with visually significant cataract and uncontrolled glaucoma, my preferred management is 1. Combined phaco-trab, 2. Phaco then trab, 3. Trab then phaco, or 4 other. And yeah, this is quite a generic question, and obviously each case has to be taken on its individual merit. But yeah, just in general, what's your approach, Peter?
In general, for disease that is not going to blind the patient imminently, my preferred choice is always phaco first, followed by trabeculectomy with anti-scarring mitomycin C. The logic being that the process of doing the phaco, the first thing you do surgically to the patient, you often make a profound difference to their vision, and that gets them on board with the whole long-term program. The next step, trabeculectomy, is much easier on a pseudophakic eye with a significantly lower complication rate. Caveats to that answer are when you've got particularly high intraocular pressure and or a brittle angle. And in those kind of cases, if I'm going to do phaco first, I'll do a phaco with 2 eye stents, which will help to buffer the immediate intraocular pressure spike. And for that small number of people who are going to go imminently blind through high pressure disease, then I'll probably do a trabeculectomy first and then think about a subsequent phaco. I don't know, what are your views, Graham?
Certainly, if you do the phaco first, a lot of studies have shown now that you want to wait at least 6 months before doing the trab, just to get the eye in that ideal state where there's minimal inflammatory response in the eye. Yeah, the problems with the phaco is that we all know that you can get significant pressure spikes post-phaco, especially in that 48 hours. So, yeah, certainly if you are planning the phaco, you want to have the pressure control as stable as possible, and do everything you can intraoperatively, like removal of viscoelastic, for instance, and even some people would consider post-operative Diamox, especially in that first couple of days, to prevent any pressure spike. And as you say, some patients don't have controlled pressures, but significant cataract, and in those sort of patients, you may well do the trab first just to get the pressure under control, because ultimately that's what's going to blind the patient. And then in those cases, if you're forced to do a phaco down the track, there's all those risks of your trabeculectomy potentially failing. If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.